Good morning. So today we are demonstrating a case of renal failure for whom we are doing two-vessel angioplasty. So he's a 64-year-old, had an inferior wall MI few weeks back, for which he was treated with primary angioplasty with stent to right coronary artery. See, during the same index event, angiogram showed two-vessel disease, a significant lesion in proximal LAD as well as LCX. So today we are addressing LAD and LCX angioplasty with ultra low volume or zero contrast. So we will demonstrate, how we are going to do it IVUS. So yeah, this is what happened. We had a difficulty in navigating our guide through the brachial artery. We sent a PTCA wire over which you can see, I'm using a seesaw movement of guide to advance the guide. So we advanced the guide over 014Y and then we advanced it into the aorta, and you can see here we just engaged guide. So this is one important thing, see, because many centers, we have been using Oxford guides in our country. So it's not advisable to use Oxford guides when you're planning a low volume contrast. If this guide won't set, I will immediately change the curve or reduce the size of the curve and go with the next guide, because guide sitting into coronary is very crucial for your rest of the procedure, and also then only it supports your IVUS catheter to go in. So once the guide is sitting in, you in fact see, I have not connected contrast here. We have connected only normal saline. So what you can do is you can inject normal saline and see what is happening in ECG. You can observe, sometimes you can see changes in ECGs, which makes you understand mostly, you are in coronary. So in this case, I have not got any changes, but it's okay. We can inject even a little bit NTZ and look at ECG if there are any changes coming in your ECG. So you can see there is a mild ST changes, okay? So which says most likely, your guide is in coronary. Anyway, let me check with wire. Yeah. So this says, your wire is in coronary. Come to epicaudal. Sorry, your guide is in coronary. So what we are going to do, since it is both LAD and LCX, we'll wire both LAD and LCX in this case, because okay, all right. Just go to epicranial. So because in this case it's a proximal LAD lesion, so if you have a wire in LCX, so there is no need to, yeah, you can see it is in that diagonal. So there is no need to, give contrast while positioning your stent into the proximal LAD. So, give me a second word, please. So as the wire is going into diagonal, so I just kept that wire there, and I'm taking my second wire into LAD. Of course, LAD has a big bend that around RVOT in this case. That's where exactly even the lesion is. So I anticipated bit difficult wiring of LAD. Let us see if it is not going. Probably I'll, give couple of ml of contrast, to visualize. Yes, yes. Okay. So this is always, important. If your first wire is not listening or not going into your target vessel, always take a second wire because that guides you better. And the first wire acts as a marker in sending your second wire. So there is an aneurysm also here. I think I need a microcatheter, please. Okay. So because of bit aneurysmal dilatation of the vessel, so it's just buckling up there. What I'll do is I'll send a microcatheter to get some support to the flexible portion of the wire, and then we'll advance uh, the wire further. Keep a trapper balloon also ready. You can see the bend which I was actually cutting. Yeah, okay. So, okay, so we could cross. Yeah, so I'm just looking at LED cords. Yes, this is LED cord. But anyway, what we are going to do now, we are just comparing with his angiogram and overall, the course of the wire. And also as the wire, in fact, gone up to apex, you can see it's almost going around the apex. So we are sure that it is only in LID. You can all as well check, epicaudal. Come to epicaudal. So that's one view which also defines the course of the wire. You can see this is typically, LED course. Okay, done. Go to cranial. Yeah. So now what we'll do, we'll remove this microcatheter after trapping, wires, and then I'll shift my, Ramus wire into LCX, and then we'll do IVUS from LED and LCX. I'm not sure whether the IVUS goes into LED because of because of the loops which we encountered, while wiring. If it doesn't go, we'll do IVUS after pre-dilatation. Okay, come to epicaudal. Talker, please. So now we'll send this Ramus wire into LCX. Okay, done. Yeah. So we are in, most likely. So I'll just confirm. Yeah, first give me IVUS. So we are just making sure. Okay, done. So the wire is in right vessel. So we are using IVUS HD. We are from Boston Scientific. Okay. Right. Yeah. So what we have to do, while doing IVA, so we know there is a discrete lesion in LCX, I'm just pulling back, okay, just to see the site of lesion. I think this is the site of lesion. It's very discrete lesion. Yeah, yeah, this is a lesion. So what I'll do now, I'll just make a cine and block it because we don't have a, yeah, uh, co-registration. I'll block it. Now I'll go down. Yeah. So you can see this acts as a distal landing zone. Okay. So I'll go further just to scan the vessel. You know how it is. So it's all fine, right? So all this work you do, and then you start recording. Okay. So yes, this is a distal landing zone. Perfect. So I'll record again. This is the distal landing zone. Recording two views. Come. Epicaudal, please. Yeah. So just record plain scene. If you have co-registration, there's no need to do all this stuff. Yes, record now. Yes. So hold on. So yeah, you can see this is a very discrete lesion. So and we already marked the distal. Yeah, this is a proximal landing zone. I think we can land here. So it's a very short lesion. Yeah. But there is also one more lesion proximal to this lesion which we have to assess by flock area and lumen area, whether we have to extend stunt up to ostium or not, because that is very important. You can see there is no flock. So I think we can ignore, say we can do a very focal stunting to LCX. Yeah. So now, yeah, now we'll discuss, our LCX assessment. So this is a distal landing. So you can see its size is around, you can see a clear EEM because it's an IWAS high definition. So you see there is 3.3 and 3.5. So the mean diameter must be around 3.4. So we can either take 3.5 or 3.25. So I mean we can even take 3.5 and deploy at low pressure. So take 3.5. So and you can see the proximal reference before. Yeah, so this is a proximal reference which is almost same, 3.3 and 3.6, it's around 3.5. So we can take 3.25 or 3.5, that's a diameter, and the length is, it came around 9 millimeter. But see, one thing very important is never take, exact length, because you end up in giving, too many injections or while positioning stunt. So what you have to make sure is if you have a good distal landing zone, I mean of a sufficient length distally and proximally. So you can see from before we have a very sufficient landing zone proximally, so that not much of block. So here there is some block. You can yeah, you bookmark here. So it's 19. Okay, done. We can also cover that block by taking 18 millimeter stunt. Yeah. So you have a good distance from ostium to your B5. So we can take 18 millimeter stent and cover that block also. Show me the lesion. See, it's looking more of fibrotic lesion. You play from B to, yeah. So you can see play. Okay. So it's more of fibrosis. But just go back to B3. See here, we have to see 3.44. No, put a dyna review. That's very important. Sometimes there can be a negative remodeling at lesion site, which you have to consider while doing stunting. See, had this patient had negative remodeling at lesion, so take another bookmark after B2. So if you find any negative remodeling, always go quarter size less, never go up, because it looks, see, you can see EM is like 3.3 to 3.9, so it's coming around 3.6. So yes, in this case it's plus or minus. So we'll just dilate with 3.25 balloon. So this is our distal landing zone. Yes, dilate please. 8, 10, 12, 14, 16, 18. Negative. So since we decided to cover even the proximal flock, so the length is coming around 18 to 19 millimeter. Just take a bit of free size. We'll go with a 23 millimeter stunt. Okay, done. Record from here. I think we have dissected. So there is a huge dissection sitting there. Yeah, but proximally it is fine. I think so. This is the proximal, yes, landing zone. So I think I marked the proximal landing zone, and you also mark ostium. So this is ostium. So never come here. Okay, done. Right? Yeah. So here there is no dissection. So we are taking 3.5 and we'll deploy at nominal pressure, right? Now you can see at the lesion site, EM area. Okay, so always keep your distal landing zone in your view and make sure your view is fixed and mag is fixed. Don't change those stuff, and then you deploy. So now I'm comfortable. So and we are not into the ostium. You can also see this is ostium, but we are not into the ostium, right? And you can also see this is a landing zone. So you can see now. So we are exactly sitting there. You can also see this is a distal landing zone, and now you see your stunt here. So I think I can come little back. Yeah, okay. So yeah, this is the stunt. Let me just reconfirm. This is a distal landing zone, and this is a yes. Deploy. Go to 8 atmospheres, please. Negative. Dilate again. 8. Okay. Negative. Just give me IVAS. So let us see in IVAS, how our landing zones are and how the stunt expansion is, and based on that we'll go to our post dilatation strategy. So this is a post deployment. IVAS. Go a bit down and record. Okay. Yeah. Yes. I think we have created a little dissection. A small dissection. Yeah. ఎలా ఉన్నారు? Okay, right. Right. ఇంకా down. Yeah, give me IVAS again. So there is definitely some subintimal hematoma. Let us see. Take IVAS again and see where is it. Yeah, yeah. Let us see the distal edge. So and then decide. And then if required, I'll give a shot. So our landing zones are perfect, but we can see the excessive speckling here. Yeah. I think from here there is, yeah, some dissection. Okay. No point in doing. Just give me 2 mm cutting balloon. Since we saw one dissection and excessive speckling in distal LCX, we'll just see how LCX is filling. You can see now, yeah, there is a problem. Yeah, that's what is reflected. Yeah. Just give me cutting balloon first. Since we had a subintimal hematoma, we had to give an injection to understand. So always, you know, make sure if something is not as predicted, don't hesitate to check. So, and in fact, all these findings, which we are seeing on angio, we have already made out in IVAS. So this is where, you know, the true lumen was. So what we do will come proximal. Yes, boss, dilate. And the vessel size was almost like 2.25. Go nominal. Since the vessel below is also too small, so it doesn't make sense to stunt it. Negative. So once we create to and fro from false to true lumen, I think usually it will heal off without much problem. And it doesn't make sense to stunt this segment, because when you stunt, you'll keep on pushing intramural hematoma down. See, now you can see a good flow in the true lumen. Speckling is reduced when compared to previous. Mm. Mm. Take SCT. 3.25 NC it's in, please. Yeah. So we have done cutting balloon to the distal intramural hematoma, and we could definitely see a change in speckling. Yeah, go to nominal, 12, 14, negative. So we can always see the edges in IVAS, and then you choose your postal test and 20 out. So we'll do final IVAS of LCX stunt. So with this, we'll close LCX and then we'll go to LAD. చెప్తున్నాయా లాసిక్స్ ఇచ్చేసేద్దాం యా ఫ్లూయిడ్స్ కూడా స్టాప్ చేయండి గివ్ లాసిక్స్ okay right your stunt areas okay done negative yeah yeah just dilate yeah 12 14 negative dilate. So we are pre-dilating LED with a 2 balloon because mid LED was not appeared, very good size. And yeah, as we anticipated, the problem for IVAS navigation dilate, please. So we thought of pre-dilating, before we do IVAS. Yeah, negative. So now we'll do IVAS from LED, and then we'll decide on, our stunting strategy. Yeah, image. So I think there is a block here. Yeah, this is a normal vessel. I think this should be the, so you can further go down. Oh, I think, is there any dissection? Yeah. Okay, let us record from here. Uh, okay. No, it's all some dissection. Dissection. No, there is also aneurysms there. I think this should be the. Huh? No, I think these are all some recanalized kind of. I think OCT will give us a clear viewpoint what it is. Mm, that's all fine. I think this is, wow. Yeah, this is a landing zone. Okay, out. Yeah. So looks like, kind of recanalized vessel or, something. Anyway, what we'll do is this acts as a good landing zone. So we can see there are multiple, channels which are visible. Probably, I think mostly it's a recanalized LED. You can see one more at 7 o'clock. You can see one more at, yeah, that's an aneurysm. So now what we have to do is, see, we'll identify that point, B2 point. And okay, I think we'll start stunting from proximal. Okay. So yeah, play from B2. Okay, so what we'll do, we'll take 348 and we'll put a proximal stunt and we'll again reassess because there is multiple channels all across. Even, angiogram doesn't give any clarity on that. So, but I think that 44 B2 is a good landing zone. So now what we'll do is we'll just mark a proximal end of the stunt landing zone in IVAS. We'll deploy 348 at low pressures and then we'll try to optimize, based on IVAS. Okay. Live imaging, please. So we can see this is bifurcation. Yeah, I'm into LED now. I'm completely into LED. Yeah, there is a block here. So what we can do is, yeah, I think this should be the nice landing point and we can observe, yeah, keep same view, don't move the view, and you see the wire, LCX wire, IVAS catheter distance, which acts as a guide, as a proximal deployment position. Give me, so I'll keep it up. Yes. Okay. Yeah. I think it's perfect. Okay. So we are just using, you can see this is the IVAS position and you can see this is my stunt. So this is IVAS and I'll show you stunt. This is perfect. Yeah, deploy, go to Okay, right. Mm. We are perfect landing. Okay, yeah, negative. I'll pull it little back. I don't want to dilate proximal or distal edge. Yes, go to 810 now. 10, yeah, out. So we'll do an IVAS and then we'll optimize. Yes, stunt expansion. Okay, so we ended exactly. Keep balloons ready, yeah? That's a site of aneurysm. That's another aneurysm. Okay. So I think we can take a 2.75. Give us 2.75 distal proximal Randy. You can clearly see a post on there. So it's almost around 3.75. Okay. So it's a 3.8, 3.6. So it, yeah, 3.75. So we'll take 3.5 and we'll go to high pressures. Yeah. If required at the end, we can dilate with a 4 millimeter balloon for apposition of only proximal edge. Yeah. So we are dilating from the place where there were couple of aneurysms visible. Yeah, dilate 14, 16. Yeah, negative. Mm. Yeah, it's wire induced. Yeah, dilate 22, 24, negative. So we almost went up to 28 proximally. So, and at 28, I think the size of 3.5 is around 3.8, right? So which is equivalent to the vessel size proximally. Okay, go up. Epicranial, please. Okay, boost. Ah, right, dilate. 12, 14, 16, 18, 20. Yes, negative. Mm, 22, negative. So the vessel is clear here, and we can see at 3 to 6 o'clock there is one lumen visible. I think kind of recanalized vessel. You can also see here around 3, 6 o'clock multiple lumens visible. Here also 3 to 6 o'clock, and yeah, it's disappeared here. So what we have to do is whether to stunt all this area. I don't think it makes sense, to stunt all this area. And we can see the stunt expansion is quite nice. And this is where the aneurysm is. So yeah, anyway, we can't oppose there. No need to attempt in opposing. And here stunt is well expanded at the site of calcium. And this is the area where it was malopposed before. We can see now it is well expanded and well opposed. Nice. Yes. So we'll take one shot. Yeah. So I'll take the wire out and see how LED is. Because of honeycombing, I'm giving one short, small shot. Okay. I think LED is nice, decent. So what we have to do with LCX, we have to decide. Come to epicortal. See, as a flow into LCX is not good, so we'll just stunt it despite cutting balloon. But the vessel is only 2 millimeter. Deploy it at low pressures. Check. Yeah, image, live please. So the false lumen is extending up to this point. Yeah. Record. Hmm. Hmm. Okay, stop. Give me iOS picture. Okay. No, it's okay. It's okay. Yeah. Yeah. Deploy. Wait. Deploy. Yeah. Go. Delete. 468. 468. Negative. Yeah. 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 Okay. Record. Yeah. Okay. Now, so there is a definite enhancement of true lumen, but it's not advisable to dilate it further because the moment if you start dilating it further and further, you'll keep increasing distal intramural hematoma would compress our true lumen. So yeah, I think this point will dilate. So here there is a lot of yeah you can see here. So we have to dilate. Yes. Give a yeah yes yeah. So here opposition is good. Don't try to dilate further because you will push hematoma down and you'll create a problem. Okay, dilate. Yeah, dilate. 12. 14 negative. Yeah, okay, overlap is dilated. Okay, right. So let me just go back and this area. Okay, it just dilate here, done, out. Okay, so we'll just do IVAS, confirm our overlap zone is well expanded and stent is well opposed, and then we'll come out. So we can still see there is a dissection flap extending distally, but we don't want to address all that stuff. And the inner stent is scaffolding true lumen very well, and it's also expanded pretty well. So if you start enhancing this space, you will reduce the distal true lumen. So we are okay with this. Yeah, and here we dilated with 3.25, you can see. So I think stent is well opposed now. So overlap zone is also, what's the pressure at overlap zone? 14 atmospheres. So we dilated pretty well. Yeah, that's fine. And this is a proximal stent. I think do it up to LMCA, please. It's always lost IVAS, even look at LMCA. So this is LMCA. We have not done anything to LMCA. So we can see this, we are coming close to the ostium. Yeah, it's perfect. Bookmark. Yeah. So beyond 6.5. Okay, done. Come proximal. So it's almost close to 7. This is overlap. I think we can give a one dilatation at overlap. Give me 3.25. Yeah, it's around 7. It is acceptable. So the block area is okay. So I think it's all 7 everywhere. Okay. I think it's okay. So done. We have given 3 injections. We completed, entered procedure in 3 injections. So you can see, sorry, yeah, this is a final LCX. The flow is good into the distal vessels. That is what we wanted, while stunting this 2.25. So we just deployed at a very low pressures and made sure, the flow is going. And the overlap zone we optimized. So, and the LED is quite nice. It's well filling. So I was showed good lumen areas, almost 7 mm proximally, and the LED is almost more than 8 millimeters. So LMCA is fine in IVAS, so we are not. So we closed overall procedure in I think 3 injections. So in fact, we had to give these injections mainly because his LCX got dissected. Otherwise, we would have avoided even those 3 injections also. Overall, we used less than 15 ml of contrast for this patient to complete procedure. The distal reference, which is 4.1 mm square. Next, we got 5.2 distal. Next, say as the patient had fluid overload situation. This is what happens when to give renal protection, we give fluids, and patient might end up in failure. Failure. Both he had hypertension and fluid overload, which caused failure. That's why we made him sit. Yeah, other areas are like 6.8, 6.3, and proximally we have got almost 8.3. This is the area where we have dilated with 3.5 balloon up to 24. Beat lost, lost. Yeah, so it's almost 12.3 mm square, and opposition of stunt is also pretty good in the proximal LID. Then show the LCX. So these are the areas in LCX you can see, 8 mm square distally. That's and next 7.3, yes, yeah, 7.3, 9.5, and these are proximal areas around more than 9 mm square. So we got good areas. So, and it's all fine. So, and we did the whole thing with less than 15 ml of contrast. Fine. Okay.